Bismillah ar-Rahman ar-Rahim. The topic of this lecture is bullous dermatoses. What are bullous dermatoses? These are dermatoses which present mainly by bulli. Not only by bulli, mainly by bulli, which means there are bulli and others. What is a bulla? A bulla is a fluid-filled lesion more than 1 centimeter. If it is less, it is a vesicle. How does a vesicle become a bulla? A vesicle becomes a bulla if it enlarges, becomes bigger, or coalescence, a few vesicles unite together and make a bulla. The bullous dermatoses are classified into congenital, immunological, and others. The congenital bullous dermatoses that you have to know is the epidermolysis bullosa, and this you're going to study in the genodermatosis lecture. Immunological bullous dermatoses, you have to study 2 diseases, the pemphigus group and dermatitis herpetiformis, and the others, or the group of diseases that are not under one title, the 4S syndrome and toxic epidermal necrolysis. We'll start with the immunological bullous dermatoses. These diseases are autoimmune. And what does autoimmune mean? This means there is a reaction towards self-antigen. There is a self-antigen from my body, and the reaction is towards this self-antigen. I react against myself. Okay. These autoimmune reactions, like any other autoimmune reactions, are very specific. They are towards one point. It is specific. Now, if I have a renal transplant patient and I don't give him proper immune suppression, his body will reject the whole kidney. But if he has an autoimmune reaction or an autoimmune disease against his kidneys, a renal autoimmune disease, the reaction will be against one point in his kidney. He would not lose the whole kidney. No, the reaction is against one point in the kidney. It is a specific reaction. The same thing goes when we are talking about autoimmunity against skin. It is also towards a specific target. The first group of diseases against from the immunological bullous disease is the pemphigus family. This is called in Arabic al-fuqqa' al-jildi. The pemphigus vulgaris is the most common of the pemphigus family, and here the pathophysiology goes as follows. The body attacks or causes antibodies against a specific point, and this specific point here is the tonofilament desmosome complex. The antibody will attack it, it will break, and fluid will be accumulated in this site. So, when the antibody attacks the tonofilament desmosome complex, it leads to acantholysis. When fluid accumulates in this area, this is called spongiosis. So, we have acantholysis followed by spongiosis. In the pemphigus vulgaris group, in the pemphigus vulgaris, it is suprabasal. The reaction here is suprabasal. The acantholysis and the spongiosis are suprabasal. What does suprabasal mean? It means above the basal cell layer. As seen in this photo here, the slide shows suprabasal acantholysis. This gap here is because of suprabasal acantholysis. It could be also diagnosed by immune fluorescence. Clinical picture. This patient, this pemphigus vulgaris patient, suffers from severe constitutional symptoms: fever, malaise, lassitude, arthralgia, pain in the joints with no arthritis. The patient has lesions on his skin and his mucous membrane. Both skin and mucous membranes are affected. We have to remember that mucous membranes are affected in almost all patients of pemphigus vulgaris. On his skin, I find wide generalized bulli. Okay, bulli distributed on a wide area of his skin. These bulli are flaccid bulli, between which there is apparently normal skin. What does apparently mean? Apparently means it looks normal. When you look at it and you examine it, it's normal, but it has starting acantholysis. So we put our thumb on our skin and we do lateral sliding. Okay? Lateral sliding, if I do it, I will find an erosion. This is because I exaggerated the already present acantholysis. So again, there is acantholysis in the skin leading to the bulli, and there is slight acantholysis in between the bulli. This is exaggerated by the lateral sliding and causes an erosion. This is lateral sliding test positive, or positive Nikoliski sign. Positive Nikoliski sign means that our lateral sliding test is positive. The bulli are widespread on the skin and on his mucous membranes. The bulli on his mouth will be ruptured before I see my patient. So I will find erosions and dribbling saliva and fetid odor. On his skin, the bulli will rupture and leave wide denuded areas, wide naked areas. Okay. They will heal eventually, but very slowly, and when they heal eventually, they're going to leave hyperpigmentation, post-eruptive hyperpigmentation. The slide shows the skin. Here is a slide. Here is one on the right, on the upper right of the slide. We find a flaccid bulli, and then the areas are ruptured. Okay, ruptured skin, a ruptured bulli. Here are areas of denuded skin, naked, ruptured. After a long time, they're going to heal by hyperpigmentation. Remember, there is no scarring. The skin in this pemphigus patient is not itchy. The pemphigus patient does not scratch. His skin is not itchy. It is a serious condition, very serious. It's one of our worst, actually. But he does not scratch or itch. Here, there are erosions on his mucous membrane because there were bulli that have already ruptured. It has to be differentially diagnosed from other bullous dermatosis. This was the pemphigus vulgaris, or the common type of pemphigus, and naturally the common type of pemphigus is seen more than the other types. There are other three types that you have to know: the pemphigus vegetans, in which there are vegetations, and these vegetations are present in the flexural areas, in the groins, for example. The foliaceous, there are crusted regions, crustaceans, and the erythematoses, there are lupus erythematosus-like lesions. Pemphigus is a very serious condition, and we have to use a life-saving medication. Here, the life-saving medication is prednisolone. We use it in a dose of 1 to 1.5 milligram per kilogram body weight per day, or 120 to 180 milligrams per day. We start with this very high dose, and then we go slowly down. We diminish our dose according to the clinical response. Other adjuvant therapies could be used in order to diminish the use of steroids, because we are afraid of the complications of these high doses of steroids. Our patient with these very high doses of steroids is liable to hyperglycemia and liable to hypertension. Both are non-responsive to regular measures. Why are they non-responsive to regular measures? Because you are on high doses of steroid and you will not remove the steroid. So you are giving him regular measures and he does not respond because he's on high doses of steroids. He has to be on serious intervention. That's why if we have in the dermatological ward, if we have an intensive care unit, he will be put in it. If not, he'll be put in a high care unit. If not, he will put in a small ward for pemphigus patients. We do have a ward here in Alexandria for pemphigus patients. If you don't have a ward, you put him in the bed that is closest to the nurse because of the complications of the treatment. The second disease you have to know is in the immunological group is dermatitis herpetiformis. In Arabic, this is called داء نبي الله أيوب. هل نبي الله أيوب كان عنده الديزيز ده ولا لا? We do not know. So we use this term داء نبي الله أيوب because it is a very, very troublesome condition. And the patient is complaining from something that we would think is not drastic. He's complaining of pruritus. But it's not like the type of pruritus that you feel if you have an insect bite or you have some urticaria or whatever. No, this is very severe pruritus. The patient starts scratching and then more scratching and then more scratching, and he enters into a frenzy of itching, and then it cools down. And this is all the time. So all the time he's liable to have attacks of severe pruritus. This disturbs his life. He cannot eat properly, he cannot sleep properly, and he cannot communicate properly. Social communication is very difficult when you want to scratch all the time. Flares of the disease could occur with gluten. What is gluten? Gluten is the protein found in wheat. It is also found in barley, but we do not use barley as food here in Egypt. Barley, shayr, we do not use it. We use wheat, القمح. القمح اللي خلقه ربنا ما كانش immunogenic، اوكي؟ اتعمل عليه تعديلات كتير قوي، اوكي؟ عشان يبقى بيطلع انتاجية احسن. فابتدى يبقى فيه problems من الجلوتين. Many diseases have to have gluten-free diet, like celiac disease, where it is life-saving. Even kids who are suffering from autism take a gluten-free diet. In the dermatitis herpetiformis, the bullae, the acantholytic bullae, are subepidermal, okay, and there are neutrophil accumulation in these in this area. Here, the patient's has polymorphic eruption, vesicles, bullae, scratch marks from the scratching, pustules from secondary infection through his nails on these scratch marks. He has hyperpigmented spots, and all this together is called polymorphous eruption. So he has the severe itching plus a polymorphous eruption, and his general condition is normal. This slide shows this slide shows the subepidermal acantholysis with accumulation of neutrophils. Immunofluorescence could also be used in diagnosis. What is the treatment of dermatitis herpetiformis? We use Dapsone in a dose of 100 to 200 milligrams per day. Dapsone is an anti-leprotic treatment. So if I ask you, what is Dapsone used for? you have to tell me first leprosy and then others, okay? Because it is an anti-leprotic treatment used in leprosy and in other diseases. We advise the patient to have a gluten-free diet, and you have to explain that this gluten-free diet will help him, okay? Gluten-free diet means that he eats without wheat. Nowadays, there are a lot of places which sell bread made of rice, and because of the patients who have autism, and they need this treatment. They need this gluten-free diet. The third group of bullous dermatoses is under the heading of others. Others means they have nothing in common. Staphylococcal scalding skin syndrome is bullous dermatosis, which occurs mainly in newborn. Staphylococci enter through the umbilical stump. When they enter through the umbilical stump, they move directly towards the bloodstream. So the patient suffers from bacteremia and septicemia. This newborn will suffer from a very serious condition which is called failure to thrive. What is failure to thrive? He cannot do what he's supposed to do at this age. What is he supposed to do at this age? Suckling. So absence of suckling reflex is failure to thrive in this newborn. He's going to have a bulla, usually a single bulla, on his abdomen, and this bulla is filled with serous fluid, which is followed by pus. The general condition is very bad, and this patient needs an intensive care unit to replace the fluid loss, which was lost by oozing, and he has to take immediate intravenous antistaph. Intravenous. If he takes it in any other form, it would not be enough. He needs it to be taken in intravenous form. The second disease in the group of others is the toxic epidermal necrolysis. This disease occurs in an older age group, not in a newborn, and it is a reaction towards a drug. You have to take proper history from the patient because if the patient is introduced to this medication another time, it's going to be very serious. This disease, because it is caused by a drug, it is a reaction to a drug, the history goes as follows. Did you take a drug? What medications did you take? What disease do you have? And if the patient goes on saying, I have no diseases, I did not take any medications, you start asking him what happened before, the night before you came to the hospital. Usually, he will tell you, nothing, I was working or studying and I felt some headache. I took some tea. Did you take medication? No, I didn't take any medication. I took a cup of tea with an aspirin beside it and I felt fine. The patient will not tell you usually about if he had taken a non-steroidal anti-inflammatory, especially if it is an aspirin, because he believes that aspirin is not a drug. It is something that he took with the tea, complementary like this. So please, you have to go into details with the patient about the drugs that he had taken, especially prior to the attack, because he will not be very helpful if it was a simple thing just as aspirin. And if you cannot take the history from the patient, you take it from people who are living with him. The patient will suffer from widespread sheets of skin that he loses. Okay, this lost skin is very serious because it is like extensive burns. He needs to go into a burn ward so that there could be proper treatment to his widespread loss of skin. Does he take steroids or not? This is controversial, But you have to know the drug that he has taken, and this drug should be stopped immediately, and the patient should be labeled that he should not come in contact with this drug again, or else this is going to be very serious, as his immunological system has been already primed. Thank you very much.